Hi, I'm Ashley. I am doing Target Zero. I know that Target Zero is backwards, but I assure you it's not just because we're being recorded. This is all the different things that we want zero occurrences on. All of these are tracked. The leadership teams at each campus wants to make sure that we are doing everything we can to keep our patients safe. So first is falls with harm. Fall patients are our fall risk patients are identified with anybody with a score of 4 or greater. These patients usually fall during, the most occurrences are during shift change. They're usually toileting related or reaching for their personal belongings. How we prevent falls is after we identify them, we set expectations during bedside shift handoff, day shift and night shift. We tell them who we are, what to expect from us, when they're going to see us, who we're working with, and we ensure them that we're going to give them great care. We also make sure to ensure that we're going to hourly round. During our hourly rounds, we're going to assess our pain, body positioning, personal belongings, their IV pump. We want to make sure that we can anticipate their needs before they have needs. And anything they may want, identify it, because we want to eliminate any reason the patient may get up without us in there and fall. Patients have responsibilities too. So we set the expectation. We expect them to call us before getting up. If they feel the urge to pee or if they feel like they might need a pee, call us and wait for us to get in. They also have the responsibility of wearing their slip socks. We're going to make sure the bed is in lowest position locked, call light is in reach, the bedside table is in reach. And every time we go in during our frequent round, make sure to point out where the call light is. The call light is by your left hand, it's by your right hand. Don't forget to call me before getting up. Wait for me to come in before getting up. Don't call me and then get up. Next, we move on to CLAB C. CLAB C is any patient with a central line, that's portacath, that's a dialysis line, it's a PIC line, a triple lumen line, a Hickman. These are patients that are have been with a line for more than 2 days and have a germ that is isolated in the blood, not related to the infection at another site, or 2 matching common organisms that live on the skin that are found in the blood. So it is important that we obtain blood cultures while in the ED or on hospital day 1 or day 2. If the patient has a central line, our job as nurses is to make sure that the dressing is clean, dry, and intact, that it has a good seal on the skin, that there's a bio patch that is placed around the insertion site. When drawing blood or accessing the port, we have to make sure to wipe the port 5 to 15 seconds and allow it to dry for 5 seconds. Do our work. If drawing blood, make sure that we change our hubcap after we draw blood out of it. It's important that those hubcaps are changed every time blood enters that site. In addition to that, making sure if we're given lipids or TPN that the IV tubing is getting changed every 24 hours. The same with primary and secondary tubing. If it's intermittently connected with secondary tubing, it's every 24 hours. We're labeling and dating our tubing. Make sure we're not looping our tubing. If you find tubing looped, go ahead and throw it away and start fresh. We have some campuses have blue caps, some campuses have white caps or red caps. Cap the end of those tubings when done. Make sure to document completely in your flow sheet the bundle. These patients also get a daily CHD wipe. Moving on to MRSA. MRSA patients at risk high for MRSA infections. They are patients that are admitted to the critical care units. Current or past MRSA infections, patients on dialysis, central lines and or indwelling Foley catheters, patients admitted to other hospitals, post-care, acute care unit, living facilities like nursing homes, rehabs, jail, patients with current or prior IV drug use. These are patients at risk for MRSA infection. If they have a current infection, they will be on isolation. These patients will also have daily CHD baths ordered. If they refuse it, make sure to remind them that this isn't just a bath, it is part of their treatment to help prevent this infection. They also will have a 5-day course of mupirocin. That's twice a day, morning and night, for 5 days in the NICU. Also, something that is super important, and I know that we do it, but to remember to check your IVs frequently. So when you're doing your frequent checks, and certainly if there's IV fluids infusing to it, look at your line. Make sure the dressing on the IV is clean, dry, and intact. It's not wet under it. Make sure that the site is normal skin. It's what we don't want is redness, swelling. We don't want to feel a vein that's really hard running up. We want to prevent that. That can be a source for MRSA to get into the blood. Caudy. Moving on to caudy. Why the Foley? Always ask why the Foley. Every time you get report from your patient, if you're receiving a patient from a unit, they have a why the Foley. There are indicators for a Foley. If they don't meet for the Foley, like if they don't qualify to have one, it is a nurse-driven protocol. We can remove the Foley. It's per nursing. Just ensure that urology is not involved and that urology did not place this Foley. Make sure that the patient, sometimes if they have really invasive abdominal surgeries, they will have a Foley catheter up to 24 or 48 hours sometimes. Before we go removing Foleys, just make sure you look at everything. Patient does not meet, remove the Foley and follow the bladder management algorithm. Bladder management algorithm is posted on every unit, usually at the nursing stations. And if you have any questions on that, just wherever you're at, ask your charge nurse. This is also, you can find this on the Ochsner app under the Target Zero section. If your patient has a Foley, make sure you document on the bundle in Epic and do the work. Super important that we make sure the catheter is secured with the securement device that is clean, dry, and intact to the upper thigh in a location where the patient's able to get up and move around, and it's not going to pull inside that bladder, that balloon pulling inside that bladder. Also making sure that the tubing is secured to the bed and that there's no dependent loops. Want to make sure that the bag is no more than 2/3 full, which shouldn't be the case, but if we're giving them diuretics, when we're doing our frequent checks, we may need to empty that more than we normally do when just doing routine intake and output. And if the Foley is no longer indicated, remember, we can remove that. It's a per nursing order. Foleys that are in for more than 48 hours cannot be cultured. If the doctor orders a urine culture and there is a Foley, stop and go get the charge nurse to help guide you if you have any questions. The Foley does have to be replaced and before we can get a culture. So why behind that is bacteria colonizes inside the tubing after 48 hours. So if you get a culture out of it, it likely will grow something and give a false positive when the patient doesn't have a urinary tract infection, which can lead to the patient getting IV antibiotics or oral antibiotics that wasn't needed. And then the obvious is do not place a Foley without an order. Moving on to PSI 3, which is a patient safety indicator 3. These are pressure injuries, stage 3 and stage 4. These patients, we like to identify, well, we do identify on admit. When we get our patients from wherever we're getting them from, ICU, a step down unit, or if we're getting them into ICU from the ED, it's important that we do a 4-eye scan assessment. It's a great idea to capture pictures of the bony prominences and put them in Epic. It's a good idea to have a baseline of how the patient came in, what their skin looks like when they came in. If they had a fall, You want to get if they have cut scrapes or bruises, but as far as pressure injuries go, you want to get a good look at their heels. You want to touch their heels, look at their sacrum, look at if they're bedbound patients, don't forget about the back of the head, back here, or even your elbows. Get pictures, put them in the chart. If they're high risk of obtaining a pressure injury, and these are identified as our patients that are over 70, incontinent patients, patients with a history of pressure ulcers, patients who have mobility deficits, patients who have poor nutrition, are skinny, frail patients. Those patients are high risk also. Put all the things that we have in place to prevent that. So some campuses have waffle mattresses, some campuses have air mattresses. If you're not sure, ask the leadership team at the campus that you're at. Put sacral borders on the backside, and then your heel protector Meplex borders, and then elevating those heels where they're floating. Not where your heels are on the pillow, where they're floating off the pillow. Sometimes you need 1 or 2 pillows, or 2 or 3 pillows actually. And then the happy bundle. The happy bundle is something that we can order. In that happy bundle, you have some wound care that you can do if it applies. Also, there's an order for dietary. There's order for wound care nurse in the Y behind it. You can put the Y in there. If they have wounds, you could click the wounds. If they're altered skin integrity, you can add those in there, or you could free text Y. We are not staging, but if you have a concern, the patient has a wound. I did do these apples because I'm visual on how to stage. So a red space with skin intact, no open skin, non-blanchable is a stage 1. A stage 2 is where it's partial thickness, the epidermis is gone. It's very superficial, so it's not, this is a stage 2. A stage 3 is full thickness without bone, skin, or tendons exposed. So it is deep. That is a stage 3. It's deeper than a stage 2. A stage 4 is also full thickness with exposed bone, tendon, muscles. So that's down to the core. That is a stage 4. Wounds that are unstageable. First is a deep tissue injury. So this is a deep tissue injury. You really can't see it on my apple, but if you were here, you could see the outline of it. Deep tissue injury could be dark maroon or purple, boggy. It definitely doesn't blanch. This will break down. We do not cut this open. This will break down on its own. And then this here is our unstageable. So it's got slough in it, and that can be any color really: green, yellow, gray, white, brown, black. It could also have hard eschar on it. These are unstageable. This wound here will not heal until this is gone. So wound care, between nursing, wound care, and sometimes surgeons, this has got to go. So it can either be with an enzymic debrider with wound care. The patient could have a bedside debridement by wound care, or sometimes the patient may need to go to the OR to get a surgical intervention so we can get the healing process going on that wound. Next is C. diff. C. diff. We have community acquired C. diff. We have hospital acquired C. diff. Our goal is to prevent hospital acquired C. diff. For patients who come into the ED who report diarrhea, it's important to obtain our stool sample ASAP. Our goal is to get the stool sample while in the ED is our goal. But if they don't have their bowel movement, we have day 1 and day 2 of hospital stay. So ED, day 1, hospital stay day 1, hospital stay day 2. That is the time frame that we want to collect our stool sample. So if you notice that patient's having diarrhea, if they're reporting abdominal pain and have diarrhea, notify the doctor and get that stool sample ordered for C. diff, rule out, place the patient on contact isolation, and send it. Our goal is to send it right away. If the patient's been in the hospital more than 2 days, so day 3 and more, and the patient starts having diarrhea, or the BPA, the C. diff BPA triggers, refer to your diarrhea decision tree. So when the BPA triggers, you're going to deviate from the protocol, and the why behind it is to evaluate your diarrhea decision tree. Go to your diarrhea decision tree. This, along with the bladder algorithm, are usually posted at all main nurses station. If you can't find it, it's also located on the Ochsner app under the target zeros. Once you have time to look at your diarrhea decision tree, put a note in. C. diff BPA triggered, patient does not meet because of this per diarrhea decision tree. Put whatever the reason may be. Also notify the doctor the patient is starting to have diarrhea, that you evaluated the diarrhea decision tree. This is what it's recommending. And the doctor will, if the patient's on laxatives, they're likely going to discontinue those laxatives. Some providers may add probiotics to the mix. So collect your stool, collect your urine, and collect your blood while in the ED if you can. There's also retained foreign objects for our surgical patients and our labor and delivery patients. To best protect them, we want everyone to speak up if they suspect something might be off. It's way better to speak up than say nothing at all. Always remember to know the crowd and be professional. But please speak up if you think that something's still in there. And then the last is wrong-sided procedures. These are for our surgical patients who are going for a hip repair, a knee repair, an appendectomy. Want to make sure right patient, right procedure, and that they understand everything. So this we start with our procedure checklist. It started on the floor or while in the ED by nursing, and it's finished in the OR. But it's super important that we make sure the patient knows what they're going for, what limit is, and that it's documented. Thanks.
Thank you.